So good evening to all of you. I'm going to talk about the patient-related complications which occurs in VA and VV ECMO. So I'm going to talk in a heading of incidence and the diagnostic workup for those patients and prevention and treatment. Now, try to understand that the ECMO complications can be divided into three parts. One is that what I'm going to talk about, the patient-related. Patient-related complication means that it is happening because of something has happened to the patient. For example, the patient has developed hypoxia. For example, patient has developed the bleeding. Now, the second complications which occurs technical, because these patients are on complex technology. Patient is an ECMO, so you will have problem with the centrifugal pump. You will have problem with the oxygenator. You will have problem with the heater. And the third type of complication is because of the cannulation and other mechanical complications, like cannula has come out or some cannula has gone down or the vascular bleeding. Because it is a complex technology, as a ECMO specialist in the future, you have to be very watchful what type of complications patient is developing, because eventually, whether it is a technical complication or whether it is a cannula related complication, impact is going to be on the patient. However, for the specialist, you have to find out what you have to do. You have to find out whether the problem is in the patient or the problem in the machine. So that's the thing how you can learn with your practical knowledge. But at present, I'm talking about the patient-related complications only. Now, we all know that ECMO patients are on very fine balance of coagulation and thrombosis. That is one, they are very high risk of thrombosis and bleeding. They are on an external circuit, so chances of hemolysis, lot of invasive procedure, there is chances of sepsis and septic shock. These complications can occur in all type of ECMO, whether it is a VA ECMO, whether it is a VV ECMO, whether it is a routine ECMO or emergency ECMO. Specific complications which is associated with VA ECMO is the oxygenation-related differential hypoxemia. Sorry. The second one is the hemodynamic problem like LV distension and loss of pulsatility. The third and the most important, most dangerous, which can cause a loss of limb and loss of patient is the limb ischemia. These are the specific complications to VA. The specific complication for VV ECMO is the recirculation and hypoxemia. So we'll try to look at the incidence according to the ELSO registry, the circuit component clots and hemolysis, cannulation site bleeding, cardiac tamponade, pulmonary hemorrhage, CNS hemorrhages, CNS infarctions, culture-proven infections, renal replacement therapy required, limb ischemia, limb amputation. So these are the complications has been reported to the ELSO, and you can see what is the incidence. And if you look at here, the renal replacement therapy is 29.6%. So this is we should try to understand, because renal AKI can occur due to ECMO also, or AKI can occur due to disease process itself. And it is very difficult to differentiate whether the acute kidney injury is due to disease process or acute kidney injury is due to ECMO. Now I'll start with a case to make it easy to understand. A 26-year-old man with a severe ARDS due to influenza H1N1 receiving VV ECMO. And the venous drainage was done by using a 25 French long multi-hole cannula with the right common femoral vein and tipping the junction of inferior vena cava and the right atrium. 18 French cannula was placed via the right internal jugular vein. This tip located in the right atrium. And the patient, while you review the patient, you find that the patient oxygen saturation has gone down what it was previous. Now, if you look at the saturation is 80% and in the ABG, and which is consistent with the SpO2 monitor in the lifted index finger. Now the problem starts here, whether it is due to machine, whether it's due to patient has got some problem which has decreased the saturation. So your systematic approach is very important. So how do you assess the hypoxia? You should first see whether my patient is getting an adequate amount of FiO2 or not by looking the fresh gas flow. Look at the blender and go for the flow calibration and look at the flow, whether RPM and the flow is matching or not. This is called excess problem if you have RPM and flow is not matching. So this is the first thing to be done when the patient has got a hypoxia. Now, if you look at the causes of excess insufficiency, means the amount of flow you want, you are not getting. And that is the most important cause of hypoxemia, because adequate amount of oxygenated blood is not going in the RV or RA, and so the patient is hypoxic and deprived of oxygen. So there can be many causes. The patient is agitating, the patient has got bleed and hypotension, vasodilatation, tension pneumothorax, cardiac tamponade, intra-abdominal hypertension, and there can be a cannular clot and malposition. So again, a combination of patient factor and a machine factor, you have to notice whether there is a clot in the filter. So if patient on ECMO has got hypoxemic, you first rule out excess insufficiency, which could be due to problem in the cannula, which could be problem in the filter, which could be problem in the patient, like tension pneumothorax, like cardiac tamponade, like the patient has got a hypotension. So if it is present, it is like ABC, like airway access insufficiency is the first to be corrected before you do anything else, and to find out what is the reason for the access insufficiency in my patient. So if you find that the access insufficiency is okay and the patient has got no problem in the flow, then you have an option to manage the hypoxemia to increase the flow. You can go up to 6 to 7 liters of flow in the adults, and a normal functional oxygenator can give up to 6 to 7 liters of flow. And usually we do that, we increases the flow. Now the question arises, if the patient is still hypoxemic, I've increased the flow, but my patient is not improving, saturation is low still, what to do? Sorry. So if your patient is not improving with 6 to 7 liters of flow, there must be some reason. And the second step is to find out whether my patient has got a high oxygen consumption or whether my patient is getting a recirculation. So by doing a pre-oxygenator or pre-pump ABG, you can actually guess that what is the reason for hypoxemia. If the saturation is less than 60%, it suggests that there is a high oxygen consumption, which can occur due to high-grade fever, which can occur due to a new onset of sepsis, which can occur due to agitations, which can occur due to tachycardia. These can cause a low oxygen saturation. But if you find that the oxygen saturation is more than 80% in the pre-oxygenator, that means you are getting some form of recirculation, and you must find out that what is the position of the cannula, and you can adjust the cannula. So this is the stepwise how we can find out the causes of hypoxemia and can treat the hypoxemia. Okay. A blood oxygen saturation in the drainage cannula below 75% may exclude a meaningful recirculation. So it is always should be less than 80%. It is going more than less than 75%. If it is going more than 75%, that means there is a mixture. And even you can see by looking at the color of the circuit that the drainage cannula is equally red as the supply cannula. That means you have a problem with the recirculation. Now, try to understand what is QECMO by QCM. Okay, so this is the ratio of the flow going to the patient from the ECMO to the cardiac output. Suppose a patient has got a cardiac output of 10 liter and the ECMO flow is 6 liter. That means 60% of the cardiac output is going for ECMO. and 40% is from the native circulation. So that is the target. At least 60% of the cardiac output should go from the ECMO. And now, if you look at, suppose the patient's cardiac output has increased by some means like high-grade fever or septic shock or sepsis, what happens? The native cardiac output increases and the ECMO cardiac output in comparison to the ECMO cardiac output. So you'll find low saturation. And in simple word, more and more oxygen consumption can decrease and can lead to hypoxemia. Now, as I told that the classic signs of recirculation is low SaO2 and high pre-oxygenator saturation. And if the pre-oxygenator is same as SpO2, there is a 0% recirculation. And if the pre-oxygenator oxygen is same as the oxygen saturation of the body, that means key venous saturation, it is 100% recirculation, and you find that both tube will be read. And we know that in which conditions there is 100% recirculation. If the heart is not pumping, if the heart is not functioning, whatever the blood, saturated blood is going to the RA, it is directly pulled out by the drainage cannula. And this occurs if if the patient has got a cardiac arrest, 100% recirculation. So the cannula distance should be maintained around 9 to 15 centimeters to avoid the recirculation. And many factors like pump speed, blood flow, intrathoracic and intracardiac, as I told you, intra-abdominal pressure, cannula type, size, position, which can affect the recirculation. It is not only the distance of the two cannulas. Now, what can we do to avoid recirculation? By increasing the distance between the cannula, as we know that we can do, or by you can also change the cannula, like you can put a bicaval dual limit cannula. We can also put an additional drainage cannula so that we can avoid the recirculation, or we should manipulate the cannula by decreasing. Now, as I told you that in any case, if the ECMO output is lower than the cardiac output, like 40% ECMO and 60% the cardiac output, the optimal should be 60% of the cardiac output. For example, 10-liter cardiac output, 6 liters should go from the ECMO. So what option we have? Many time it is due to sepsis and septic shock. So we have to manage that. We have to achieve a moderate hypothermia. We can give a beta blocker if blood pressure permits. We should provide adequate sedation and analgesia. Or you can have the option to tolerate a decrease of CO2, because if the patient is slightly hypotensive, then oxygen delivery and hemoglobin should be improved. And we can also go for increasing the ventilator effect. So the message is that if you think that the hypoxemia is due to low ECMO flow, or you're not the ratio of the cardiac output is lower in that means less than 40% or 50%, then the treatment or the management according to the totality of the patient condition. Not one thing is going to improve your patient. So you have to think, like patient has gone into septic shock and hypoxemic. You might have to transfuse the blood in this situation because you do not have an option to go for a beta blocker. You might have to go for a hypothermia. You might have to sedate and paralyze the patient. So according to the way you manage the patient in intensive care unit, the same principle will apply. That only thing difference is that try to achieve a higher ECMO cardiac output, try to increase the ECMO flow also. That will increase the cardiac ratio of the ECMO to total cardiac output. Now, the other option, like particularly in ARDS patient, if a patient is not improving hypoxemic on ECMO, so people have tried proning the patient on ECMO, and many trials have shown that this is feasible and there is no additional complications if you prone the patient. And the benefit is that your patient lung mechanics improve and hypoxemia. But recently, one of JAMA, we have published one of the trial in COVID patient where the proning has improved the PO to ratio, but no survival benefit. Anyway, but if an intensivist and ECMO specialist do not have any option to improve the hypoxemia, patients should be prone. That will improve the hypoxemia of the patient. Now, so far we have discussed a VV ECMO. Now, hypoxia can occur via ECMO also, and that is more dangerous than the hypoxemia of the VV ECMO. And look at the case. You can go through the case. A 41-year-old man is supported with the peripheral VA ECMO. Peripheral VA ECMO means that you are taking blood from the femoral vein, and that means IVC, and then you're supplying to the external iliac artery or femoral artery. So he presented 3 days ago with the STMI, and the percutaneous coronary intervention was complicated by a pulmonary aspiration during intubation. He got ARDS, and despite revascularization, he had a progressive cardiogenic shock, which was placed on VA ECMO, and the circuit was running without any problem. But now you find that his oxygen saturation is gone down to 82%. Now, what is difference in hypoxia VA ECMO? Always says, as I told you, that man and machine in ECMO is very important. As a physician, as a specialist, you have to see the patient, you have to see the machine, you have to see the ventilator, ECMO monitors, everything. The causes could be a loss of pulsatility. The causes could be oxygen saturation measured from where you are measuring the oxygen saturation. Is there any pulmonary dysfunction like ARDS, or are the ventilator settings appropriate? This is the patient-related cause. The ECMO machine-related cause could be if the ECMO blood flow is adequate to the patient, and if the oxygen delivered to the oxygenator. These are the causes. And if you look at your finding is that this patient has a femoral VA ECMO configuring the unchanged circuit and blood flow is 3.8 liter. The oxygen saturation in the right arm is fallen to 82%, and measured 99% the left arm. And we know that we rely on the right arm saturation finger. The oxygen 100% is connected, and there is now a very good pulsatile waveform is coming in the arterial trace. That means the heart function has improved and the ventilator setting is appropriate. The pre-oxygenator saturation is 75%. So if this is the situation where you find a saturation difference between right and left arm, and you find that upper and lower part of the body, this is called Harlequin syndrome, and this is called a differential hypoxia. And try to understand how it happens. Suppose you have put the patient for cardiac dysfunction, cardiogenic shock. So this mixing, like this is the blood which is going to from the descending aorta towards the arch of aorta, and this is the blood coming to the arch of aorta. Usually, if you have a very poor cardiac function, this mixing occurs somewhere in the abdominal aorta. But if you have a very good, if your cardiac function is improved, try to understand it again. If you have a poor ventricular function, the pulsatility of the ECMO flow and the aortic and the flow from the LV mix somewhere near the arch of aorta or near the ventricle. But if the ventricle function has improved, like in our patient, again, so this is deoxygenated blood. Why deoxygenated blood? Because your patient has got a ARDS also. So lung is also working as a large shunt. So your upper half of the body is getting deoxygenated blood. Upper half means cerebral and coronary both. So what option we have if your patient has got Harlequin syndrome or North-South syndrome? Now, what we can do? The first thing we can do, we can decrease the ECMO flow. That will improve the uh, mixing. You can modify the ECMO configuration also. You can you can go for a VV ECMO. You can stop all the inotropic support, or you can convert into the VV ECMO, because there is no need for the VV ECMO if your heart function is good. So you can convert to VV ECMO to manage the ARDS patient. So conversion to VAV, conversion to VV, decreasing the any inotropic support, and sometime you can also go for axillary cannulation that will improve your oxygenation. So these are the different options you have in north-south syndrome, which is one of the complications of VECMO. And this typically occurs if a patient is suffering with ARDS and shock, and the cardiogenic shock has improved, but ARDS has not improved, then there is a possibility of mixing, and that can lead to differential hypoxia. Now come to the one of the major complication of ECMO, that is the infections, and the prevalence is hospital-acquired infection during 10 to 12%, but recent ELSO data has shown there is a very high prevalence in Indian scenario, and particularly gram-negative organism and MDR organism. And it is very difficult to blame the ECMO for the infections, because many patients who are admitted in the ICU who are going for the ECMO are very sick patients and already infected patients. For example, a patient who has got a H1N1 pneumonia, viral, but 4th or 5th day he is going on ECMO. He already has some or the other form of bloodstream infection or a bacterial pneumonia. So, because of the critical illness, they are very high risk of hospital-acquired infections, and mostly they are gram-negative organism. And as you know that the organism are both those who are in the ICU, colonizer, and ICU infections. Now, the management of infection is not different from the ICU. Only thing is that if you find that the patient has got a bloodstream infection, you are not changing the cannula. You can change, you are even not changing the central line also, because high risk of bleeding. So we try to give higher doses of antibiotic, and then empirically, and then modify according to their culture sensitivity report. Okay. And if the patient has gone into sepsis and septic shock, and particularly if the patient has got a fungemia and fungal infections, they are on very high risk of death. So prevention of the infection is very important, and management and early treatment is important. Now come to the other complication of VECMO. Like you have put a patient on VECMO and you find that the patient has gone into pulmonary edema, a pink fluid coming from the ET tube, and what is the option how to investigate? Now, a 39-year-old male was commenced with a peripheral FEMFEM VECMO with cardiogenic shock following the late nutrition of enterolateral stream. ECMO flow 3 liters per minute. On the second day, he becomes progressively more difficult to ventilate, and you notice that a large volume of pink fluid coming on his endotracheal tube. What can be done acutely in such patients? Like if you do an echo in such patients, what we are finding here is that a grossly elevated stress, and X-ray you can find that the patient has gone into hemorrhagic pulmonary edema. This because there is no very little pulsatility in the LV, whatever the pulsatile arm is slightly there, but LV is not contracting, is extraction not more than 20%. If we not manage, these patients are not going to survive, because they will die of the pulmonary edema, and eventually they might have thrombus in the heart. So what can be done? The increased people reduce their stress to the LV, and that may reduce LV preload that we can do it on ventilator. We can go increasing the inotropic supports, increase the contractility of the heart. We should apply a CRRT to decrease the volume. We could also go for intra-aortic balloon pump that can increase the cardiac output. And finally, if the patient is not improving, you have an option to go for a LV venting. Now, if there is, look at this algorithm, if there is no pulsatile ECMO and the pulmonary edema has increased, like pink Frothy fluid, you do echo. If echo is showing that there is a LV distance and stasis, aortic valve is not opening. Now try to decrease the MAP and try to decrease the ECMO flow and decrease the volume. Increase the additional inotropic support, apply the IABP. If there's no improvement, you can go for ALS septostomy. You can go for direct drainage of the LV, or you can apply an impella. So these are the different options you have to manage the pulmonary edema and LV distension in patient who's got a ECMO. And look at this patient who has 2 days later, and there is a sudden threefold increase in the vasopressor requirement. The arterial line is traced and has gone from upper and lower. You can see what has happened to the patient. The patient, the previous scene, you can see the red line, blood pressure was 100/57, but there was a pulsatility. Here again, there's no much change in the blood pressure, but the pulsatility has gone. That means this is what is happening. Why? The myocardium is turning, the pump failure, the patient has got hypovolemia, bleeding, or the patient has got cardiac tamponade or LV discharge. So if you find on the ECG is initially there was a pulsation, the first thing is to do echocardiography. Try to find out what has happened to your patient, whether it is a further worsening of the heart, which may be due to hypovolemia, which may be due to contractility or cardiac tamponade. Now we know that the signs of pump failure, and you can find out in the echo, there is a vascular distension, and then chamber size, then abnormality. These all things can be done. You can find out the signs of cardiac tamponade, pericardial effusion, dilated IVCs, systolic collapse, and you can also go for D. And if this is the situation in a central ECMO, you have to go for sternotomy, and this is a real emergency if you will not emerge, because you are not going to train, because the patient is also on heparin, so you need to involve the cardiovascular surgeon. The loss of pulsatility could be due to hypovolemia and bleeding also, and a small LV cavity, hypercontractile LVOT, VTI less than 12, and collapse IVC. So what I'm trying to convey to you is that in a ECMO patient, a loss of pulsatility could be signs of pump failure, signs of cardiac tamponade, and signs of hypovolemia. By clinical examination, you cannot do anything. So you have to do urgent echo, and then you have to find out what is the reason, and then you have to intervene. Now, the other complications are already also discussed in detail by Dr. Pabani sir. You can have a bleeding 17%, intracerebral hemorrhage, and you can have a thrombosis also. Now, the various degree of disseminated intravascular coagulation occurs in ECMO patients. These patients are only heparin. They will also have acquired von Willebrand disease, consumption coagulopathy, sepsis in particular, and the bleeding depends upon the systemic anticoagulation, platelet dysfunction, and there is a fine balance between the coagulation and thrombosis in ECMO patients, and these patients are high risk of bleeding, not only because they are on heparin, but also because of these factors which I have enumerated. So one of the prevention measure or preventive measure is that a very close monitoring of coagulation parameters. The most frequent source of bleeding is cannula site or surgical site. In central ECMO, the surgical site is the most common site of bleeding. The cannula site is also. Bleeding can also occur in the lung, can occur in the GI, can occur in the brain. If the bleeding is visible, you can apply a topical things like you can have a fibrinogen sealant. You can in the cannula site you can apply that can control. Site you can apply the pressure that can control the bleeding. And maintaining a target coagulation parameters and a balance between ACT, APTT, and thrombotic parameters are very important for the prevention of the complications. I'm not here going to talk about the management of bleeding, but one thing is important. If you have a major bleeding, you have to heparin. And don't hesitate in stopping the heparin, because if you are maintaining a circuit flow of 4 to 5 liter, there is a less chance that your patient is going to have a circuit clot. But be aware that you should keep a circuit or oxygenator ready, because clots occur suddenly and you have a little time to change the circuit. This is again, you can see that the bleeding has occurred, and one of the risk factors is long-term ECMO and rapid hypocapnia. Very important. If patient before putting on ECMO has a high PCO2, more than 100, 110, don't correct it very rapid, because it can cause a change in the hemodynamic of the brain and can cause bleeding. So if the patient has tolerated it, control it also if you are gradually correcting the hypo and not 10 to 20, 10 to 15 mm of Hg per hour is required. Okay. This type of patient already discussed, and that there are three options. If you have a patient of intracerebral bleed, stop the heparin, and you can go for emergency decannulation. If you can go for neurological intervention, and also registering only 11% of the patient on VA ECMO and 26% those with PV ECMO who has developed ICS survived to the hospital discharge. So this is one of the very, very dreaded complications, and which has a very high impact on the ECMO continuation and the mortality. Now, thrombosis, again, not very common on the cases of VA ECMO, but very dangerous on the not common on the VV ECMO, but very dangerous on the VA ECMO, and particularly if the thrombosis occur in the femorals, that can lead to a ischemia and limb ischemia. That's why we always put a antegrade reperfusion cannula if you are putting a peripheral VA ECMO, and try to control the balance the anticoagulation in such patients. Now, look at some of the important things, particularly in VA ECMO. If you are trying to decrease the flow, you should reciprocal. You should increase the ACT in the reciprocal manner. Like if the flow is around more than 2.5 liter, less chance that there is a coagulation. 160 to 180% ACT is okay. But if the flow has gone to less than 2 liter, like when you are giving a weaning trial or weaning the ECMO, VA ECMO particularly, then the high ACT has to be maintained to prevent the bleeding, to prevent the complications of thrombosis in such patients. Now, very important vascular complications. If you are running ECMO, if you in future want to run ECMO, you should must know how to prevent, how to treat, how to recognize a limb ischemia in patient who has got a VA ECMO. The combination of femoral arterial cannulation with a large bore cannula and a hemodynamic instability like non-pulsatile flow during the peripheral VA ECMO places the limb at the risk of thromboembolic complications. Now, a large bore cannula, usually we try to keep cannula size less than 20 French in cases of the VA ECMO. Now, the risks are greater with a large cannula, more than 20 French. The clinical presentation varies in the severity from pain, pallor, pallonikia, motor and sensory deficit, and gangrene. The Doppler ultrasound and NIRS are non-invasive tool to evaluate the vascular insufficiency. And nowadays we are also monitoring with the we are checking the flow also in the reperfusion cannula. Now, tissue saturation by NIRS should be above 50% and preferably 60%, and there should be a less than 20% difference between the two extremities. Means yeah, to adequacy of the flow, the best way to monitor with the NIRS and clinical monitoring and Doppler monitoring, and a combined and comprehensive monitoring is required. Now look at this picture, you can find out that in the left side, the distal perfusion cannula has been placed and the NIRS monitor has been placed, and a limb which is getting good perfusion. Here the limb is again bad perfusion to this limb and limb ischemia is there. Now vascular injury, again, it is related to the cannulation, it is related to the it is exactly not related to the patient, it is related to the cannulation and the person who is doing the ECMO and sometimes moving the cannula, and this can occur in 17 to 40% of the patients. Now come to the other complication, which is you should must pick up and should not lose. Why the urine bag is getting red? If you look at this urine bag, is getting red. So hemolysis after about ECMO occurs in 1 in 5 patients. That means almost 20% chance that a patient might have hemolysis. This because the patient is on large flow and the patient is passing to the oxygenator where thrombus is there. Maybe some clot in the cannula, that all can cause hemolysis. And the ELSO guidelines says that the plasma hemoglobin should be less than 0.1 gram per dl under most conditions of the, and if it is should be investigated if it is more than 0.5 gram per dl. Okay, the causes can have the excess insufficiency, as I told you, the pump head thrombosis and the oxygenator thrombosis. So this is related to the machine, this is related to the patient, which is manifesting in the patient by hemoglobinuria. Now, to summarize the hemorrhage and, sorry. Just a minute. Hemorrhage and infections are the two main complications related to the ECMO. The arterial cannulation is related to the high risk of bleeding. The hemorrhage can occur in any organ. Intracranial bleeding is the most devastating. The ECMO management includes close coagulation monitoring, ensuring the best possible balance in coagulation and homeostasis. The infective complications can be related to the catheter, but mostly it is related to the sickness and critical illness of the patient, and we need to strict monitoring, and we need to have practice of asepsis in each patient. A distended non-contracting left ventricle on echocardiography requires urgent intervention. Hypoxemia and ECMO should be approached systematically. Thank you for your patience listening. If you have a question, I am ready to answer.